All right, why don't we go ahead and get started? Um, it gives me great pleasure to introduce Dr. Elizabeth Boggs. Dr. Boggs is an assistant professor in the Division of Hospital Medicine, clinically based at the University of Colorado Hospital. She completed her undergraduate degree at Colgate University before going on to Case Western Reserve University, where she completed her MD degree. She then moved to the University of Pittsburgh, where she completed a combined internal medicine pediatric residency. She then completed a 2-year medicine pediatrics fellowship at Northwestern, where she also obtained a master's of science in healthcare quality and patient safety. We were fortunate to recruit Dr. Boggs to the University of Colorado 2 years ago. Her area of expertise is the impact of healthcare policy and programs on vulnerable populations, including those of low socioeconomic status, with a focus on evidence-based interventions to reduce readmissions for patients with Medicaid. With her background in medicine and pediatrics, she has published on the barriers to transition from pediatric to adult care in young adults who have chronic conditions. And Dr. Boggs will be sharing her expertise with us today with a talk entitled Supporting Patient Transitions Within the Healthcare System. Dr. Boggs?
All right, thank you. So my name is Elizabeth Boggs. I'm a hospitalist and junior faculty researcher at CU. And like Dr. Austin was saying, today I'm going to be talking about one of my main research interests, which is how we can support and optimize patient transitions of care within the healthcare system. So transitions of care within the healthcare system is a very broad topic, and my research questions around it have evolved as my clinical practice has evolved. So when I was practicing as a med-peds hospitalist, seeing both adults and children, I frequently encountered young adult patients with chronic conditions who really struggled with that transition from pediatric to adult care. And so that's where I started with my research. But then moving on to take a position as an adult medicine hospitalist, one of the most pressing issues that my patients face is the inpatient to outpatient care transition. So once I finished my med-peds hospital medicine fellowship, I became more interested in post-discharge transitions. And while these are two very different types of movement through the healthcare system, I think one common element to both these types of transitions is that they are a very vulnerable time for patients. So I'm going to spend the majority of the time talking today focusing on the transition from pediatric to adult care, and then I'm going to switch gears to introduce a study that was just funded related to the inpatient to outpatient transition. So starting with transitions from pediatric to adult care. So first of all, what do we mean when we talk about this specific type of transition? So the transition from pediatric to adult care is ideally a purposeful, planned movement of adolescents and young adults, oftentimes with chronic physical and medical conditions, from a child-centered to an adult-oriented care model. And that's in contrast to a transfer, which is the actual discrete event where we move from a new healthcare setting, provider, or both. And that ideally is just one component of the longitudinal medical transition process. So what does the ideal transition process look like? This is a timeline that's borrowed from the Center for Healthcare Transition Improvement, which is endorsed by the American Academy of Pediatrics, American Academy of Family Physicians, and the American College of Physicians. And what you can see here is that the transition process actually starts around the age of 12, with the pediatrician approaching the patient and or the family to talk about the next few years and the preparation for the actual transfer of care, which ideally occurs around age 18. And then ages 18 to 22 is when this patient is sort of transferring over to the adult side, and then 23 to 26 when they're really being integrated into the adult care model. So I'm going to start with a patient case to illustrate some of the challenges that patients face in this process. And just as a disclaimer, this is not a patient who was seen at CU. This was a different institution. So while some of the challenges highlighted here might not apply at CU, the literature suggests that this patient's experience is not unique. And I think that we could assume that there are different barriers and challenges the patient would face within our system. So this is a 26-year-old woman with a history of infantile onset metachromatic leukodystrophy. She was treated with a bone marrow transplant, and she came into a pediatric emergency department when her gastroduodenostomy tube was dislodged. So a little bit more information. She is nonverbal and she's brought in by her mother, who's her primary caregiver. She has a tracheostomy tube and is ventilator dependent. And she also has her GJ tube and she is tube feed dependent. And in addition to that, she has a ventriculoperitoneal shunt. So a little bit of background on her transition journey. So it took her pediatrician over a year to identify an adult primary care provider to take over her care. About 6 months before this ED visit, she had been transitioned officially to an adult primary care provider. She has 9 different subspecialists who are involved in her care, and some of those are on the pediatric side. Some of them have been transitioned over to the adult side. So she's kind of got care on both sides of the fence there. But despite her pediatrician looking and her family looking, they have been unable to identify an adult gastroenterologist who has been willing to take over the management of her GJ tube. So at this institution, adult GI really didn't use GJ tubes and just didn't have that expertise to manage her device. So as far as her clinical course goes, so the pediatric ED provider, seeing that she was 26 years old and had already transitioned much of her care over to the adult side, elected to transfer her to the affiliated adult emergency department. And when she arrived there via ambulance, interventional radiology was consulted, but they were unable to replace her GJ tube because the hospital did not stock a small enough tube size for this patient who weighed 22 kilograms. So she ended up being transferred back to the pediatric emergency department for care, where radiology there was able to put a new tube in. But even months after this happened, both the primary care provider and the family have still been unable to identify an adult gastroenterologist to manage this tube outpatient. So this patient's experience is obviously not an ideal outcome. And I think the question that arises from it is, how often does this happen where patients are sort of stuck between pediatric and adult care? And when we look at the pediatric to adult transition literature, the take-home message that we see over and over again is that the population of adolescents and young adults with chronic conditions is really growing faster than our ability to provide age-appropriate care for them. So with advances in medical care, the life expectancy of these patients with chronic conditions is increasing, and we just don't have the infrastructure in our healthcare system to adequately support them. So when we look at the actual numbers here and why this is relevant, there are over 30 million people in the US between the ages of 18 to 24, and almost a third of those have one or more chronic conditions, which puts us at about 9 million young adults in the US with a chronic condition who are trying to transition to adult-centered care. So this is a substantial and growing population that really needs adult providers who are willing and able to assume care. But what happens when we actually try to transition these patients? So what we see is poor health outcomes during the transition process across a variety of disease states using a variety of different outcome measures. And these are just some examples here. So we have in type 1 diabetes, poor glycemic control. In patients with sickle cell disease, we see increased acute care utilization. Patients with congenital heart disease have increased morbidity and need for intervention. And then transplant recipients have increased incidence of graft failure around the time of transition. So this issue is really ubiquitous regardless of the diagnosis. So one question you might be wondering is that if outcomes are poor around the time of transition, when we try to move patients from pediatric to adult care, why do we do it? Why don't we just have pediatricians continue to follow these patients into adulthood, particularly the really medically complex patients like the one we talked about earlier? And this may be obvious, but one of the reasons for that is that pediatricians are not particularly well equipped to deal with the emergence of adult onset diseases, things like high blood pressure, coronary artery disease, type 2 diabetes. On the inpatient side, we have increased risk of venous thromboembolism that pediatricians aren't used to managing. So I think it's really ideal for patients to be cared for in the appropriate setting for their chronological age. So when we think about the process of transition, what are the commonly encountered barriers? What are the things that contribute to these poor health outcomes? And when we look in the literature, the list is exhaustive. There's a couple that I want to just focus on right now, focused on the adult side of this transition process, because a lot of the barriers happen on the pediatric side as well. So the first major issue is difficulty identifying adult providers who are willing and able to care for childhood onset chronic diseases. And there have been studies showing that adult providers feel like they really have inadequate training to competently care for childhood onset chronic diseases. In addition to that, we have the very real logistical barrier of appointment times on the adult side. Sometimes adult primary care providers just don't have enough time in the day or appointment slots based on reimbursement to address all the complex needs that these patients present with. And then another major issue for patients who are technology dependent, like the one that we talked about, is difficulty identifying providers who can manage medical devices that were placed in childhood. And I think that the second issue is really interesting to me because it was something that came up just so frequently in my patients when I practice as a med-peds hospitalist. And on the one hand, you have the issue of a patient who, say, has a CNS shunt or VP shunt that's placed in infancy, and maybe it's been revised, 4 times on the pediatric side. And I'm not a proceduralist, but I can understand why a neurosurgeon would be hesitant to take over care of that patient. But on the other hand, you have providers who are willing and who are able to take on these patients, but their institutions literally just don't stock the right size or the right type of device that the patient needs. And so anecdotally, I was seeing more and more young adults with medical devices that were struggling with this transition process. And I felt like it was a really interesting and growing problem that was understudied. And I really wanted to explore that further. So for the purpose of the study I did, I defined technology dependence as an indwelling medical device that's required to maintain health status. And the reason that it's important in the transition process is that it's often a surrogate marker of involvement in multiple subspecialty services, increased requirement for care coordination, increased acute care utilization, and then increased risk of readmission when these patients do come into the hospital. So there's really not a whole lot of existing research on the prevalence and trends over time in patients with technology dependence who are preparing to transition to adult care. And I really think understanding this is critical to anticipating the future needs of patients with chronic disease and to prepare as a healthcare system to take care of these patients. So in looking in trends in technology dependence, my study objective was to look at the prevalence, types, and trends over time of indwelling medical devices in patients with chronic diseases who are at the age of transition to adult care. And my hypothesis was that the prevalence of technology dependence would increase over time as the number of patients with chronic diseases surviving to adulthood increased. I did a retrospective cross-sectional cohort study to look into this, and I used the Pediatric Health Information Systems, or PHIS database. And this is a national database with demographic, diagnostic, and procedural data from about 50 tertiary care children's hospitals across the country. And I looked at patients who were hospitalized in one of these children's hospitals from 2008 to 2018 with a childhood onset chronic condition. So the reason I was looking only at children's hospitals was because I was interested in young adult and adult patients who hadn't yet transitioned. So despite being at or above the age of transition, there was something keeping them in the pediatric system, and I wanted to explore the role of technology dependence there. So I looked at patients with one or more of 6 commonly studied chronic conditions that originate in childhood. And the reason I chose these 6 conditions is because, one, they're very commonly studied. There's a lot of literature about all of these. And then also because they have associations with complex medical needs. They represent a range of organ systems, neurologic impairment, and technology dependence. So I looked specifically at brain and spinal cord malformations, which includes things like spina bifida. I looked at cerebral palsy, heart and great vessel malformation, so patients with congenital heart disease, cystic fibrosis, sickle cell anemia, and chronic renal failure. So looking at the demographic and clinical characteristics of these patients, I know that I said this was trends over time, but just looking at 2018 for the most proximal year of data that we have, I think the take home point here is that when we look at age groups with these chronic conditions, over 7% of patients seen at children's hospitals are at or above the age of transition. So to me, that's a really substantial proportion of patients being seen at pediatric hospitals who are in fact adults. And then the second point that I want to highlight here is that in patients with one of these conditions, the prevalence of technology dependence was very high. So around 35-36% in patients under the age of 18, and then in the low 40s for patients 19 and over. So again, these are all patients who are past the age of transition to adult care. And when we look at trends over time, so we have in this graph, so we have the x-axis is time from 2008 to 2018. On the y-axis, we have percentage of patients with technology. And if we look at the solid black line here, this is all patients. So starting around 30%, the proportion increased to a little over 35% by the end of the study period. And then if we look at the solid triangle here, we see that in patients who are in the pre-transition period, so 16 to 18-year-olds, again, a statistically significant increase in the proportion of technology dependence over time. And then again, looking at 19 to 21-year-olds, this dashed line here, statistically significant increase. And then for patients over 21, this line here, a substantial proportion of them were technology dependent, but we did not see that statistically significant change over the course of the study period. So this, I feel like, really kind of confirmed my hypothesis that this is a large population that's growing and that this is a growing problem for us to face as a healthcare system. And then in order to inform what specific devices we need to be ready to care for on the adult side, we looked at which devices were the most common in these conditions. And again, this is just looking at 2018, but what we found were that feeding tubes, CNS shunts, and tracheostomies were made up about 40% of the devices that we were seeing. So again, just take home points here, a population of young adults with chronic diseases with technology dependence who are getting ready to transition is substantial. It's increasing over time. And the most common devices we need to be ready to care for are feeding tubes, shunts, and tracheostomies. So I think the implications here are that we really need strategies to support technology dependent patients who are transitioning to adult care. And these strategies can take a lot of different forms. I think one of the lowest hanging fruit is just partnering with central supply at adult hospitals to procure appropriately sized devices, understanding that there may be an influx of patients who are smaller than or lower weight than the patients we're used to caring for. I think can certainly be residency curriculum for both internal medicine and procedural subspecialists focused on transition and focus on devices specifically, what devices are used in pediatrics and how they can be managed in adult patients. And then for those of us who are already out of training, CME for educational activities that are related to management of either common devices or these childhood onset chronic diseases. And then strategic use of MedPeds providers, which is something that we're going to be doing here at CU soon, starting a MedPeds consult service to support providers both on the adult side and the pediatric side in caring for some of these patients. So as I mentioned before, moving to a new healthcare system and taking on a new role, practicing exclusively adult medicine brought to light an even more common transition within the healthcare system, and that's inpatient to outpatient. And right now, I'm most interested in supporting the patients who I see struggle the most with transitioning out of the hospital. And what I've seen in my time on the adult side is that the process is particularly challenging for patients with Medicaid, who often have fewer options for disposition, more barriers to outpatient follow-up, and experience more readmissions. So I'm going to talk about a study that I'm currently conducting that just received funding. So it's very early and I don't have much in the way of data to present. So I'm going to focus more on background and research questions. So when we think about post-discharge transitions, one of the big concerns that both patients and providers have is readmissions. And what we know about readmissions is that they're prevalent, they're costly, and oftentimes they're preventable. And patients with Medicaid are disproportionately impacted. So the average rate of readmission nationwide for adults with Medicaid is around close to 13%, and that's in comparison to around 8.7% for patients with commercial insurance. And this costs us each state about $77 million per year. And when we look into reasons why patients are readmitted, we see that there's extensive literature on strategies to reduce readmissions among Medicare beneficiaries. So for example, in the Medicare population, there are intervention bundles that address multiple factors related to discharge care coordination, including prominently timely outpatient follow-up. But then we have comparatively few studies on strategies to reduce readmissions among Medicaid beneficiaries. And I think that's a really important knowledge gap because patients with Medicaid face unique challenges in post-discharge planning, and those include limited access to primary and subspecialty care, discontinuous insurance coverage, housing instability, inadequate transportation. And for all these reasons, I think that the lessons that we have learned from patients with Medicare may not be applicable to patients with Medicaid. Those intervention bundles that have been developed in the Medicare population may just not translate to better outcomes for patients with Medicaid. So I think that understanding drivers of readmission among Medicaid patients in Colorado is particularly relevant right now, not just because it's incredibly important for quality patient care, but also because Colorado is introducing the Hospital Transformation Program, which is a new method of payment that's going to go live in April, so tomorrow, with the goal of improving the quality of hospital care that's provided to Colorado Medicaid members. So what's going to happen is that Medicaid hospital payments are going to transition from a pay-for-process to a pay-for-performance structure with the goal of improving health outcomes. And two of the really important pay-for-performance measures are going to be rate of post-discharge outpatient follow-up and then rate of hospital readmission within 30 days. And that's a risk-adjusted metric. So unfortunately, as we kind of discussed before, we don't have a ton of data on hospital interventions that consistently reduce readmissions among patients with Medicaid. One intervention that's been studied extensively in different populations, particularly the Medicare population, is the impact of post-discharge follow-up on readmissions. But when we look at data on the Medicaid population, the literature here is really conflicting on the role of post-discharge follow-up and reducing readmissions. And part of that, I think, is that when we look at these studies in the Medicaid population, they use very, very different study populations. So some look at the general population, some focus exclusively on patients with physical disabilities or chronic conditions or mental health issues or substance use disorder. So really hard to draw generalizations from that. And then also a lot of these studies are older. They were performed before Medicaid expansion, which may have increased access to outpatient care and kind of changed the relationship there. And I would argue that one of the implicit assumptions of the Hospital Transformation Program is that post-discharge follow-up is linked to reduced readmissions for patients with Medicaid. And I'm just not sure that we have clear literature to support that. So because the studies on patients with Medicaid are pretty heterogeneous in their results, and because so many patients with Medicaid have social determinants of health that impact their care, I think that the answer of whether post-discharge follow-up actually reduces readmissions is yes, probably for some patients, but the question is who benefits from this approach and who should we target as a result for evidence-based interventions to reduce readmissions? So in thinking about what patients stand to gain the most from post-discharge follow-up, it seems natural to me to look at patients whose admissions would have been avoidable with adequate access to outpatient care. And to do this, we can look at ambulatory care sensitive conditions, which are defined by the AHRQ as conditions for which good outpatient care can potentially prevent the need for hospitalization. So examples of these are things like community-acquired pneumonia, UTIs, complications from diabetes and hypertension. So an example here would be a patient with type 2 diabetes who maybe has Medicaid insurance and is waiting to get in with endocrinology and runs out of their insulin prescription and then ends up in the hospital for DKA or HHS just because they didn't have good communication with their outpatient provider and maybe didn't have a timely clinic visit to address that. So the first thing I'm going to do with this study is look at the impact of post-discharge follow-up for patients at UC Health with Medicaid who are admitted for ambulatory care sensitive conditions. And then assuming that there is a relationship between post-discharge follow-up and readmissions among this very specific cohort of patients, the next step is going to be to examine accessibility of outpatient follow-up for patients with Medicaid at UC Health. And the literature shows that in general, patients with Medicaid wait longer for outpatient follow-up. And if that's the case here at UC Health, then that's something that we may want to address in order to succeed within the context of the HTP. So I'm going to do a retrospective cohort study looking at adults ages 21 to 64 with an admission for an ambulatory care sensitive condition from 2017 to 2019. And the data set I'm using is Health Data Compass, and then I'm linking that to the All Payer Claims database to make sure that patients who were initially seen here and then maybe had follow-up or readmission at a hospital outside of our system, that I can still capture those patients. And this data is hot off the press, so it's not, it's a little rough around the edges, but just looking at readmission within 90 days, this data has not yet been cut for the 30-day cutoff, but we see that patients with commercial insurance, about 12% of them have a readmission within 90 days in comparison to close to 17% of patients with Medicaid. So higher numbers of patients with Medicaid getting readmitted, which correlates with national data. And then as far as future directions for this work, so right now I'm collecting the baseline data pre-HTP implementation, but I want to do a pre and post comparison to look at the impact of the program on both Medicaid patients in general, and then those who are admitted for ambulatory care sensitive conditions. And then I want to take that a step further by doing a complementary qualitative analysis of the patient experience with this program to explain quantitative results. So just wrapping things up, I want to extend a huge thank you to all my mentors and advisors who helped with both of these projects. And I'm happy to answer any questions that come up.
Great. Thanks, Elizabeth. That was an excellent talk. I just posted into the chat room for our participants, we're in the audience, the virtual audience, to post questions. Marisha with a nice comment. Great job. So I guess one question that I have while we're waiting for others to think about their questions, in terms of the transition from peds to adult, I can think obviously of family medicine physicians as well as med peds physicians who are trained in both, I guess, who might be better equipped. I guess I wonder whether most med peds physicians or even family medicines physicians tend to, over time, focus on either a pediatric population versus an adult population, or do they continue to sort of see that? And is that part of what might make it a challenge to get continuous PCP follow-up? And then sort of related to that is, even for those that do a med peds fellowship, residency, some will go on to do a fellowship, but it's usually almost exclusively either in medicine or pediatrics. And so, does that, I guess, the extent to which, I guess, at least if you were an adult gastroenterologist who did a med peds residency, you'd be a little better prepared maybe to help with that transition. But anyway, I know that's a long, complicated question, but maybe first tackle the sort of PCP, family medicine, and med peds, and then sort of the subspecialty aspect.
Yeah, and I don't mean to suggest at all that med peds providers are or family medicine providers are perfectly capable of flawlessly navigating patients through this transition. I think it is very challenging for all providers to really do a good job of supporting patients because this is an incredibly complex process. The last time I looked at the data, and this was admittedly several years ago, I think there were about 50% of MedPeds residency grads went on to practice on either side pretty exclusively, and then about 50% did some sort of combined work, whether that was in primary care or some sort of combined fellowship. So I think that med peds and family medicine can be part of the solution, but it is certainly not the solution, both
Right.
because we don't necessarily have a transition curriculum as part of our residency. It's just we see both sides and it's like, wow, this is really crazy what patients experience, but
Right.
we're not necessarily getting the education on like, hey, how do we make this better? So I think that providers who are trained on both sides can be tools, but not the entire solution by any means.
Great, thanks.
Not sure if that answers your question.
No, it did. Yes, it did answer the question. I think what is probably a challenge is just the overall burden, the complexity of taking on a patient who transitions out of pediatrics into adulthood, whoever they're going to see, and it can be, if your clinic becomes filled with high medically complex patients, that is really challenging. So
yes, yeah. It's incredibly challenging. And then on the pediatric side, I think there are a lot more like social workers and care coordinators that are sort of embedded in these clinics that take a lot of the work off the physician, and those resources just aren't the same on the adult side. So I think it makes it incredibly challenging.
Right. Other questions for Dr. Boggs? So I'll follow up on the Medicaid.
Okay.
So I did a study a few years ago. We looked at the bariatric surgery population at the University Hospital and actually looked at insurance, and the Medicaid population actually did well in terms of weight loss, just as well as all other patients with different payers, but they had a higher readmission rate. And I think a lot of those readmissions, I think, were for potentially preventable, whether it was just hydration, they couldn't get into a CUPCP, or so I'm certainly familiar with that aspect. I guess is it that even though we've expanded Medicaid, has that actually made it harder for the average Medicaid patient to actually have a PCP? Do you see what I'm saying? Because we didn't expand the supply of primary care providers, but we expanded that population, and many practices either have limited or no ability to, or don't accept Medicaid. And I just wonder whether that actually, because we did expand the overall population, whether it actually made it globally just more challenging to actually get those patients providers. Not that it would have been any easier if they were completely uninsured, but
right. Yeah, I think I've seen some studies in not specific to Colorado, but like in Michigan, for example, suggesting that after Medicaid expansion, there was more connection with primary care providers. But I do think that that's access to care, whether or not you have insurance, there's still a ton of room for improvement there in patients with Medicaid. And I'm hopeful that the hospital transformation program will provide more of a financial incentive for us to really look at, like, okay, how easy is it for a Medicaid patient to get into one of our clinics?
Right.
And if not, how much are we being penalized for that through this program? And maybe kind of shift the scales a little bit so that we can really look at that. But I agree, it's still a huge issue.
Right. Great. All right. I don't see any additional questions in either the chat or Q&A. I'll give sort of a countdown for any final a 3, a 2, a 1. All right. Well, with that, I'd like to thank Dr. Boggs for joining us, giving us an excellent talk. Thank you, all of those of you who joined us virtually, and we'll see you next week. Take care.
Thanks so much.
All right.